ECP might be the most well-researched medical device on the planet. There is so much data, good, scientifically valid data. It's not all in the US, but a fair amount of it is. But it's, it's good studies where, regardless of where the studies were done at.
This is What About Rural Health podcast, and I'm Chinasa Imo, your host. Today's conversation is about our ongoing series, Rethinking Rural Health Financing, Investment Opportunities and Challenges. We will be discussing rural healthcare and the EECP access crisis with our guests, Jack Clifford, a patient advocate and the founder of EECP Locator. Welcome to What About Rural Health, Jack.
Thanks, Chinasa. Super excited to be here.
Thank you. Welcome. So, how is your day?
Good. Yeah. It's a sunny day in Florida. Perfect weather, like normal.
Yeah, I mean, we have a very hard our weather here in Chicago is high, but funny enough, we're in between rains. So we're having rains and we're also putting on our ACs.
There you go.
Okay.
There you go.
All right, let's go. Every day, people around the world survive because they are able to reach healthcare on time. Others die, not necessarily because the treatment does not exist, but because there are barriers between them and care. In parts of rural Africa, a woman in cardiac distress may need to travel hours by motorcycle to reach the nearest clinic. In America, the story may look different, but the challenge remains whether ordinary people can also reach care on time. So the question is the same. What is the value of medical innovation if the people who need it the most simply cannot access them close to their homes?
Yeah.
When it comes to heart health, we often imagine care as immediate, sophisticated, and available. An emergency room already prepared, a standby specialist, a streamlined procedure, a hospital that is bright, and filled with machines just waiting. For millions of rural patients, healthcare is very geographical. Your zip code can determine how long you wait, how far you travel, what treatment options you are able to get, and sometimes whether you even survive at all. So today's conversation begins with a sentence no patient ever forgets. If you live that long. Those were the words
You don't
that
forget those.
Clifford heard.
All kinds of light bulbs go on.
Yeah, exactly. And those are the kind of words Jack Clifford heard after being diagnosed with 100% blockage in his large artery, commonly known as the widowmaker. His doctor recommended triple bypass surgery, but Jack said, no, that is not enough for me. He went searching for alternatives and discovered EECP therapy, a non-invasive cardiovascular treatment that he said helped his body grow new pathway around the blockage. Now, here is where the story becomes larger than one man's survival story. Despite decades of research and FDA clearance, EECP remain largely inaccessible in many rural communities across the United States. There are only a few hundred providers nationwide. What this means is that many rural patients who may need this treatment are forced to travel hundreds of miles repeatedly just to access care. So, today we are not just focusing on heart health, but also on the innovation that already exists, the geographic problem, and the rural health infrastructure, and the incentives that continue to shape access to cardiovascular treatment, both in the US and globally. So, Jack, I think this is a point where I bring you in, and I know that our audience would want to know who you are. So, can you briefly introduce yourself and tell us what led you to work around ECP therapy and
Sure,
patients
absolutely.
advocacy?
Yeah. So, uh, I can very much relate to all these rural health challenges that you mentioned, and I live in a hospital that has one of those big, fancy, shiny hospitals. I guess, fortunately, depending on your perspective, but um, I was in one of them, and needed something much more basic. EECP that we're going to mention today is not one of those high tech shiny therapies. It's 30 years old. The
Wow.
machines that most people use are around that time frame, 20, 30 years old. But that's what I needed. That's what worked for me, and yet I couldn't find it in my local community. I had to drive 3 hours and stay in a hotel, which most people don't have the resources to do, and I barely have the resources to do. Um, and yeah, that's the situation with external counterpulsation. So, how I got into that space is, like you mentioned, I was sitting there in a hospital being offered nothing but bypass surgery for all three of my vessels. So I'm 100% blocked in my widowmaker. I'm 95 in the left, and I'm 80 in the right to this day. But I can run a sub 7 mile now, so I don't have blockages that limit me in any way. There's no reason to do surgery on me. I don't need a stent. I haven't had any of those procedures. I used the ECP therapy instead, but it was really hard to find. I had to be really determined to have found it and used it. And for your rural health listeners, like, this is a really big deal. I mean, it's a big deal because maybe they can't get to one of those big shiny hospitals like you mentioned to get the life-saving procedure, but um, also because there's these alternatives out there that are much more financially feasible if we're talking about it from an innovation and a financing perspective. You don't need a big shiny hospital with all the latest gazebos and gadgets. In many cases, you might just need this 30-year-old technology with this machine that might be 20 or 30 years old that can help the rural health patient get to exactly where they need to be, which, in my case at least, in my experience, is a much better place than having had this really. I like to do this little crossover here because this is the surgery you might see if you see somebody at the swimming
Yes.
pool and you see that you're like, oh, you had a bypass surgery. I could go into all the really specific reasons why, but that's where it started with me in that hospital and looking at the bypass surgery, which my mother had had 5 years before, and it started her cognitive decline that unfortunately led to her being in memory care right now. And I didn't want to even risk that unless there was absolutely nothing else that could be tried. But I wasn't in an emergent situation. The hospital tends to want to frame things in these emergent terms, and I'll really paint that picture for you. Like, I went to the hospital with a really bad case of angina that was serious, but I didn't have a heart attack, and that was ruled out in the emergency room. And yeah, I got admitted because they put me on a stress test, a nuclear stress test, and I failed that miserably, which meant there was something I needed to take seriously and be evaluated. Then they put a big patch of nitro paste on my chest, and they hooked me up to all these gizmos and gadgets and made me feel like my life was dependent on them when it wasn't at
Yeah.
all. They were going to wait till Monday. This was a Friday. They were going to wait till Monday to do the heart cath that would have led to the bypass surgery because in my case I was just that blocked up and it was completely unstentable. But I'm making the point that they framed it in emergent terms, but they weren't acting emergently. And yet I had this nitro paste on me I didn't need. I was hooked up to all these gizmos and gadgets that were beeping all over the place that were doing nothing for me. And I had all weekend to think about it. Thank God it was a Friday. Right? And I had my phone. It was during COVID. I had nothing else because no one could see me. I was alone in a hospital that I had just moved to the area. I didn't really know anybody outside of my family. And but I had heard about EECP. I had heard about it looking into alternatives for my mom if something had happened to her again. And I was just aware of it. Part of the problem here is, you know, uh, some of these, let's say, really productive and promising therapies don't really ever see the light of day or the audience that they should see. And a lot of them are like low tech, really applicable to rural health where we can deploy these things quickly. They could be financed for dollars that are not insane. And I had just heard about it, but I didn't know how it worked. I didn't really look into it. What I did know is the closest provider to my mom, who was in a rural health area in North Carolina, was 2 hours away, and you have to go there 35 times to get a full course of treatment done. And my mom was at her age was not going to be able to do that. 2 hours one way, 2 hours back, 35 times within 7 weeks. It wasn't going to happen. So I moved on. I didn't really think about it much more, except I knew that it existed, and then it was my turn in the hot seat. I was like, I'm really going to look into this now, and that's what I did. So.
Thank you so much for sharing this, for sharing your story. I really appreciate that. And it resonates with a lot of the conversation that we are having about the impact of distance. Like you'd mentioned, 2 hours going, 2 hours coming back. Who will do that for 35 times?
Not anyone I know. They can't. Who can? I mean, you got the gas money, you got the time off work or the time away from your obligations.
Yeah, but yeah, but that is when we look at the economic the economic purchasing power of people and cross spectrum. Right. Not everybody have the ability to own a car or even have someone that will drive you all this back and forth for 35 times that you need to have it. So thank you so much for sharing. I wanted to add a follow-up question to you. While you were in the hospital for this weekend brainstorming and thinking about your life, what did all of that conversation, both from the medical perspective, and I see and I hear you mentioning low tech for rural people. And I appreciate that because sometimes we hang up in the high conversation about high technological advancement that we can brag about. But low tech have shown to actually be very life-saving. And many of them have existed for a very long time, but we jettison them for the pursuit of the new shiny thing. So
and then everybody forgets about the stuff that's been working for
a very long time. Exactly. Yes. So how did it, during this period, I want to crawl into your headspace and think, how did it help you, imagine the entire US healthcare system? Like, you think about it, they make you angry and stuff.
If you or someone you love is dealing with heart disease, there's a therapy you probably haven't heard about. In his book, EECP, The Most Underutilized Therapy in Medicine, Jack Clifford shares how he avoided bypass surgery using a non-invasive FDA-cleared treatment. Visit eecpbook.com and use our discount code podcast-free to download the book for free.
Yeah, so I'm scared at this moment 5 years ago, right? I'm frightened to death. I'm not the guy sitting here that feels confident in the choices I made and where I'm at and the outcome. Then I was just terrified. I think like most people would be. I mean, we could talk about it from a couple of different perspectives, but one I'd like to highlight is when you get in that vulnerable situation, you're kind of like putty in a lot of other people's hands, right?
Yes.
And one aspect when you talk about it from a heart disease perspective is pretty quickly we all get like super sensitive to every little signal our body gives us, right? And so if I feel anything in this area, it's like, oh, it's the big one, which I think is a pretty normal reaction, right? Pretty soon I'm just like so paranoid that the paranoia just feeds the cycle, and when I left the hospital, I was really in that situation where I was like, I'm going to die. Is there somebody that can resuscitate me? Can somebody cart me off to the hospital if I drop dead right here? But in that moment, it was really challenging to stick to my guns. I got a second opinion, which felt like the right thing to do. And another team of cardiology folks came by and evaluated everything and talked with me. And they gave me the same exact recommendation. And then when I left the hospital, to talk about what you sort of introed with is, the doctor's like, I said, hey, doc, I just moved here. I guess I need a cardiologist now. Can I come see you next week? And he says, if you live that long, just walks out the door. And, if I wasn't sober before, I was definitely sober after that.
Yeah.
But I still left. That was the point where I was like, oh, I'm really doing this. Okay. And then, every little thing after that until ECP started to make me feel better and gave me confidence, which takes time, was, oh, is that the big one? You know, is it like it was, it's a really, going against the grain is very, very difficult in our medical system. They do not make it easy for you. And they also, like you mentioned, you know, about your rural health books, they don't, you know, they're chasing the new shiny thing that's often, you know, expensive and hard to make available, and, you know, jettisoning often all of these, you know, much more basic solutions. And ECP cannot be more basic in its principles. You know, how it works is not hard to understand. When we get to the place where I can explain it to your audience, they're going to be like, oh,
Sure.
that makes sense.
Sure. I wanted to add a follow-up question because I had a question to say, how did you discover EECP?
Sure.
But then you've answered that. So I'm just going to add a follow-on question to say, what made you think, or what convinced you that this is worth trying?
That's dated a little bit. So my wife and I have been biohackers. I like to call ourselves master level biohackers, not that that's any official term, but since 2008. And the only reason was out of desperation because my wife had a series of health issues where doctors really didn't have answers. They offered her, you know, chemotherapy type drugs, some of it actually for cancer, some of it for autoimmune disease, but nonetheless, like, it wasn't even like supposed to stop the progression even, you know. So I would just maybe buy her a little bit more time, and then that, and then a traumatic brain injury, which was much more difficult than the other two diagnoses. But nonetheless, like, doctors ended up just not having answers for what she was dealing with. And so if we didn't go find those answers, we had no answers, and we were stuck. And I could have very much lost my wife and life partner of 32 years. So we were forced into that space. But when we saw that there were certain things that worked that we had to research and find out, and often had to then find providers to help assist us with, but those providers weren't finding us, you know, there were very few and far between that you had to really seek those folks out. We got kind of comfortable operating on our own, you know, and so I was open to there being alternatives, and kind of just presumed at a certain point, after so many years of that happening time and again, and you're like, nobody told you about this thing, but this is actually the thing that worked for the thing that my wife was dealing with. Now all of a sudden I'm in the hospital, and I've seen my wife go through all this pain and, you know, difficult situations, dealing with difficult issues with her body, and she always stuck to her guns, you know, like she just found a way. And I'm like, well, gee, it's my turn now. Like, I'm not going to be a chicken and just, you know, follow the path they lead you down. Yeah. Because I don't know that I could really look my wife in the eyes. And, you know, she was scared. She wasn't even like sure that I was doing the right thing, but, you know, she was trying to encourage me at the same time. There's some points where she was just, you know, like they scared her too. But yeah.
So I'm just also going to ask, at what point did you realize that this is definitely working? And while you are answering that, can you give us like a roadmap between when you started the treatment and now, how you feel, how your life feel?
Yeah, and that's interesting because, you know, we want everything in a pill typically. You know, we want the solution in a pill, and we only want to take it once if possible. You know, one pill. Like, we all want to just scratch off the winning lottery ticket, but we only want to buy one. You know, like that's too often our mindset, and that's, you know, not usually how the good things come packaged up. But ECP is like that. You know, you get sort of out of it what you put into it in a lot of ways. But you need that foothold that you're like, okay, I know this is doing something, you know, so that I'm willing to invest more time and energy and resources in continuing. And so for me, that was probably, I had a couple of different tells. My first challenge was I had to get somebody to treat me. So the problem with EECP, very specifically, not the problem, several challenges with it. One, it's only reimbursed if you have what it roughly amounts to end-stage angina. So you have chest pain that is aggravated by like walking around and stuff. So you're almost like housebound. They call them like cardiac cripples.
Mm.
And also add to that that your cardiologist has to also say that you can't have another bypass and another stent or and so like you don't really have you don't really have real insurance reimbursement for this, unfortunately, even though it is reimbursable under certain circumstances. So that's not to say that people couldn't find a way to get it reimbursed, but it is FDA approved for angina, for heart failure, and for cardiogenic shock. Interestingly enough, also for general circulation improvement and VO2 max increase. It's important. That might come in handy later in this discussion. And so getting the treatment was really challenging. There was only about 15 providers in the whole state. None of them were close to me. And I live in a big state. I live in Florida, where there's a lot of old people. Everybody knows that. Like, a lot of heart,
15, like
a lot of
only
heart patients.
15 provider in Florida,
Yeah, the whole state.
the whole state.
Yes, and
Okay.
it's a big state, and geographically, and so I called around, I chased down all these leads about who might even have a machine, and then when they would use it, and I even went to some providers, and I got nobody would work with me. Finally, found a doctor that seemed open, but he was 3 hours away, so I drove up, and he made me do all these procedures. I ended up having to do a heart cath with him at a hospital that does not do bypass surgery because it was so small, which was a blessing because that wasn't even something I had to be concerned about. Because it's important to note too, when you're going into a heart cath procedure, this is where they could be putting stents in you, right? And that's what I think everybody hopes for. In and out, you throw a stent in, and then the problem is solved, and that's not really a solution, but it'll help your symptoms. But what you consent for typically is that if they go in and they can't do the stents, then they can go put you into bypass. And so you go under thinking you're getting a stent, hopefully, and you wake up having had a bypass surgery is a whole different thing. These procedures do not compare to each other in terms of recovery or risk or anything. And not that stents are risk-free because they're not. But anyhow, so he made me do a bunch of workups, and then he did agree to treat me with the ECP first, which was important. I had to stay in a hotel, and I had 19 sessions with him over 4 weeks, Monday through Friday, one a day. I was working, trying to work in the hotel and take sick leave, in between to get over to get the treatments. It was really challenging for me on a bunch of levels, being away from my family. And somewhere in there, so I developed my own little stress test. People might hear it as a stress test or a treadmill test or a nuclear stress test. It's all very similar terminology. I was like, well, I have to know I got to know this is working, right? My life is on the line in certain ways, and I need this to get better, not worse. Even though I have time, it's got to go in a certain direction. So I just got on the treadmill at the hotel, and I try to learn my body and find out where the chest pain would come in. This is also kind of important to think about angina as a supply-demand mismatch in the heart. So if I'm sitting here talking to you and I'm as blocked up as I told you and I hadn't done the work with the EECP machine, I have no supply-demand mismatch potentially sitting here having this conversation. But if I get up to go walk around the block, maybe I get to supply-demand mismatch. What happens at supply-demand mismatch? Well, the blood flow is not equal to, in the coronary arteries that are all blocked up with plaquing and atherosclerosis, are not equal to the demand, and that results in chest pain, which they call angina. And it can feel like a lot of different things, but it's generally, pain that feels like it might be deep in your chest. Yeah. So I had to learn to kind of flirt with that, right? I'd get up to that place, but not push it, because when you stop, when you fix the supply-demand mismatch by stopping, then very quickly it should resolve if you don't push it too far. Now, if you push it too far, it can last for days. It's really not fun. So in this case, what I saw was when I started I could walk at 2.2 miles an hour and I wouldn't get chest pain. But if I went to 2.3, I would.
Wow. Wow.
That's not very fast. And then by the time I had that 19th session and I was testing myself every night in the hotel, I could get to 2.7. That's a half a mile increase, but percentage wise, that's a lot of,
Yes.
2.2 to 2.7. And so I was really encouraged. Some other things happened. I'll tell you a little funny story because I'm just like a really pretty open guy. I had really severe erectile dysfunction. I was kind of in like denial about it. And that was more a product of like, hey, I've been married a really long time, and like people's sex life evolve and change, and I just like I don't have all the answers for how denial I was, to be honest with you, because it should have been. So I wrote a second book called the circulation solution, erectile dysfunction and vascular healing. And it's just, I got a little funny tagline because I tell a story about the canary in the coal mine, and then we're like, your penis is the canary, because it always predates heart disease by years. And so if people really listen to their body, they'd be like, whoa. Anyhow, and I should have done that. I didn't. And then, if you go to your doctor and you get Viagra, they're like, oh, problem solved. No, problem's not solved. But that being the case, the funny was there was kind of a cute little 20-something technician. You're on the machine, you're wearing yoga pants, like real tight yoga pants, and then they strap you into all these cuffs, and then one of them's right over your groin. And then, at a certain point, she has to unwrap you to get you off the machine, and then like I'm like, whoa, and I was like, oh, something's different. Because that was a very spontaneous, like I wasn't attempting to make that happen in any way, shape, or form. So I tell that in the book, but it's a common experience with the EECP guys. They're like, pretty much every guy that's been through EECP's got one of those stories that I just told you. It's a very awkward moment in your yoga pants.
Thank you very much for sharing your experience. It's really helpful, especially for others who might be going through this and maybe don't have that much of information or exposure to recognize all of this. You are very intentional in the way that you had monitored your system, and be curious in knowing when you begin to see improvement. But let's go for a quick break.
Looking for EECP therapy, but don't know where to start? EECP Locator is the only dedicated directory helping patients find EECP providers near them. Whether you're exploring options for heart health, circulation, or recovery, finding a provider shouldn't be the hardest part. Visit eecplocator.com and find an EECP provider today.
All right, welcome back. So, the story is powerful, I must say. And but I think it made this conversation interesting, or what made it interesting is that many people listening may never have heard of EECP. And I know you've mentioned that a lot. So can you slow it down a little bit?
Sure.
And explain to us what EECP therapy is. What does how does the procedure work, and why do some people describe EECP as as a passive cardiovascular exercise?
Absolutely. So a quick little bit on the history. This was developed kind of jointly with Chinese scientists in the U.S. And China took it back and did one thing with it, and now there's 5,000 access points all over China. That's part of standard care. And in the U.S., we did something else with it, and so it resulted in a very different outcome in terms of how ECP is used. But so the technology is over 3 decades old, and it's actually the availability of the therapy and the FDA indications and approvals and the little bit of insurance reimbursement we have is 3 decades old. The technology dates back, we've been working on this in some form or fashion since like the 50s. Like you mentioned, passive cardiovascular exercise. Although I like to add this, Janyasa, because I don't want anybody thinking that they can just go, figure out the passive, their own version of it, because you can't. It's passive cardiovascular exercise at supra physiologic levels, meaning levels that a human being could not perform. It doesn't matter if you're Usain Bolt or whoever. Like, you can't put your body through this level of cardiovascular exercise. And you're doing it lying down while you often fall asleep as the machine pulses to the beat of your heart, and it's so hypnotic, and just it's a pleasant experience. For the most part, once you get used to the pressure, we'll talk about that later. But anyways, so you lie on a bed. You have cuffs on your calves, your thighs, and your hips on both sides, and you have a 3-lead EKG. So it's got a EKG connection here, down here, and here. And there's an EKG readout that your technician is monitoring. And when they hit the button, the machine starts to pulse in between heartbeats. Every heartbeat it pulses. And it inflates with air pressure in those cuffs at 1.3 pounds per square inch, which feels kind of like a gentle massage. And then you go up in increments of 0.1 up to 6.0 pounds per square inch, which feels like the opposite of a gentle massage. However, your body gets used to the increase in pressure over one session and over multiple sessions until that pressure just becomes increasingly tolerable. And that pressure, the tolerability of that pressure is your body responding to the therapy, right? Acutely in that moment, but also over time, because each session stacks on the previous one. So it's important that they be done close together timing wise, over days and weeks and months. But it gives your body this stimulus, and we're all familiar with we tried to do something that was physical and it was hard, and then we did it again and it was maybe a little bit easier. That's exercise, right? Like, that's our body's adaptation to, this is just that principle, but taken and sort of like put on massive steroids. So it's just way more different. But what the effect is that your body grows vasculature. It grows new vessels. So we all have these things called collateral vessels, which are kind of these dormant channels that, when they're unused, think of them like muscles, and so they wither and die if they're unused. But if you use them regularly, they're strengthened and healthy, just like somebody that uses their muscles versus somebody's a couch potato. And these vessels, these blood vessels throughout your body that are collateral vessels are like that. But also, you can grow new ones entirely, and I'll just show you a little, so we can see this, right?
Yeah.
Okay, I got the same one over there. I like to show that because it might be a little unsightly. I don't know, but I don't care. But I grew those with the EECP, and they feed my brain. Mm-hmm. And incidentally, a study was published. Today's the 18th of May, and so on Friday, a study was published about how EECP fixes dementia. It was published in a very good journal 2 days or 3 days ago. And if you want to know why, and so so it's just a function of time and pressure. Time on the machine and the pressure you use. That pressure is the stimulus that your body has to adapt to, and it's going to make whatever adjustments it needs to make to make sure that the stimulus, this blood from your lower body that's being pushed into your upper body, is that the pipes get big enough to fit all that blood that you're telling all of a sudden this it works in your legs too, mind you, because that whole blood returns back. It's not just like the upper body that it works in, but you're saying, hey, you got to be bigger because these pipes are too small, and then they get bigger and they get more of them.
I wanted to ask you, and I think you are alluding to that already, that a study came out that you also fixes dementia. And a little bit of my own reading, because I'm curious about what EECP can do. I saw mentioning of, its impact on long COVID, diabetes, and some other kinds of comorbid issues that are related to cardiovascular health. Can you talk a little bit about that?
Yeah, so this is probably the area that I'll light up more than anything else. So it's approved to fix these heart issues, right? And it does a really good job if you do it right and you do it long enough. Because I'm the guy that's sitting here who's 100% blocked. Like, I'm the guy that couldn't walk more than 2.2 miles an hour 5 years ago, who has had no intervention, is on no heart meds, and can do, some pretty impressive cardiovascular stuff for a 52-year-old guy. But when I, learned about this, and, I need to add just some clarity. I didn't just get 35 hours because I was very blocked up. I ended up getting my own machine, and I have on 700 hours. So, this is a function of time on the machine for some of the stuff I'm going to talk about. Although, like you mentioned, long COVID, it's study for long COVID. That's a 35-hour study, and it was 80% successful with treating long COVID. The dementia study was similar. It was initial 35 hours, and they had, I think, once a week or twice a week for the remainder of the study for up to 6 months. And then they studied outcomes out to a year. But ECP might be the most well-researched medical device on the planet. There is so much data. Good, scientifically valid data. It's not all in the U.S., but a fair amount of it is. But it's it's good studies regardless of where the studies were done at. And EECP is a systemic therapy. We're talking about the blood growing all over, right?
Yeah.
And I had symptoms here, and these were clinical. After I did about 10-15 hours on the machine, I started getting tingling in my toes. Well, what is that about? Well, I was probably pre-diabetic and had, some level of neuropathy that generally starts further down your chain in your extremities, right? Because the tingling was pretty pronounced, and then it just went away. And what it was replaced with systemically is I have a very different sensation of touch now over my whole body. I give more hugs because it feels really good to me. I mean, I hope it's good to other people, but I wasn't like that guy particularly before. I mean, I just have a totally different sense of touch, as a sense. I mean, all of my senses are heightened, but so like, it's well studied to revascularize your kidneys. And in my opinion, if you took advantage of ECP versus going on dialysis, if you caught it early enough, when you were heading that way, but soon enough, you could probably avoid having to be on dialysis, period, if you did it right. That's a postulation on my part. There's not data for that. There's good data for erectile dysfunction. Like, and people are popping pills, and they're getting implants in their penis, and they're putting needles in their penis to make their penis work. And this fixes, like, the root cause. Like, it fixes it. A whole different level of therapy from anything else that's out there. Like, we talked about dementia, right? These demented patients should be getting worse. A year in a demented patient. I lost my dad to dementia before I knew about ECP.
I'm so sorry about that.
Thank you. And a year is a long time. Like, there's generally a fair amount of progression. They all got better. Over the course of a period of time, they should have gotten worse. They all got better, and markedly better. They blew past their inputs, what they expected and what they saw, way better. It's really well studied in like performance enhancement. Like the VO2 max increase, the stem cell release of the hematopoietic stem cell line. So any stem cell that can become a blood product or an immune product, really well studied. It is studied in Parkinson's disease. I don't know if I could say well studied, but there's valid studies and reasons for being really optimistic that it could be really helpful. I could really go on all of these other off-label conditions. Like there's just so much, because really, if the limiting factor to the diagnosis or progression of a disease is blood flow, which in most diseases it's in the mix somewhere, and some of them, a fair number of them, like it's the root cause, then ECP probably plays a role. Because everybody knows if you could put exercise in a pill, we'd all be popping it left, right, and center. This is the closest thing you're going to get to that. You're lying in a bed where you can fall asleep, and you're getting massive cardiovascular exercise benefits at the same time. Like it
So,
doesn't get any easier or better.
so essentially, what you are describing is a treatment approach that tries to improve circulation and encourage the body to develop alternative blood flow pathways.
Exactly.
But despite the research and the FDA clearance, at least in the US, many people still know little about it.
Now you're gonna get me angry. Oh,
Well,
yes.
let's go for another short break. When we come back, we'll dive into what this means for rural health.
If you're enjoying this conversation, don't forget to subscribe to What About Rural Health on all podcast streaming platforms. We are on Spotify, Amazon Music, Apple Podcasts, Listen Now, and so on. And yes, we are on YouTube too. Your support means a lot to us. Please like, leave a comment, share, and most importantly, give us a review. It helps others discover this important conversation.
Welcome back. You are still listening to What About Rural Health with Chinasa Imo. All right, so this is where I think the rural health conversation comes in, especially when we consider the demography that need this more.
Mhm.
You would find them to be aged people or people living with comorbid condition, like I'd mentioned people before, people who live in rural, suburban, or urban disadvantaged environment who are potentially going through this stress. Why do
Yeah.
you think there are far less EECP provider in the United States, even with the country's advancement in medical
Well,
technology?
let me firstly say that I am on a mission to change that, and I've got a lot of people that I think are really like getting behind this and excited to see something move and change in this space. I've got
Okay.
a lot laid out there that over the coming months and years I think is gonna. So my personal goal is I'm declaring it unreasonable for anyone to have to drive more than 30 minutes to an EC access point, and that means that we need to have an access point every 30 minutes across the United States, anywhere you are. And at the point that we get there, I actually can just rest and chill, and I don't know what I'll do next, but that's what's going to happen. And then if you want to try EECP, and hopefully we can get insurance reimbursement as well with more indications and stuff, which we're also fighting and advocating for. But at that point, it'll really be a choice. But I want to highlight one thing real quick. If I had gone through that bypass surgery, and I know my insurance would have paid $50,000, maybe more, to a bunch of different people. None of them me, and none of them you. But like a bunch of pockets would have gotten lined as I got this scar, and God knows what else I got from that surgery, right? That I'd have to live with for the rest of my life if I lived through it. And I paid $22,000 for the EECP machine that I've been using for the last 5 years that made all of that stuff and a whole lot of other stuff I might have had just because I was getting older and I had all these other issues I wasn't really dealing with that I haven't burdened the healthcare system with. Like the insurance company could have bought that for me very easily. I've been getting myself on and off that machine for 5 years. My wife's been using it. She gets herself on and off of it. Like, you do need some training and some monitoring at a certain point. But we need to bring these to the people, whether that's an EC access point or whether that's providing an in-home machine that we train people on and monitor them with so that they can get this therapy in their home, which it doesn't get any better than that. We got to get these to the people. I'll also say that the technology has not been static. It's been pretty static in the US, but like I mentioned, China has innovated and they have 5,000 access points. And they have portable machines that don't even need beds, that are on wheels, and you can just put them in the corner and you can wheel them to the next person if you need to. And, the possibilities are limitless for how quickly we can get ECP to the people if we just embrace the technology among other solutions. Like a quick little for example, because I want to say one thing to your listeners. One, get a hold of me. I'm making it really easy for people to get a hold of me right now on the websites. I'll have a conversation with anybody about ECP and we'll brainstorm together. And I'm not charging people for that. I just want to help people. But also, on EECPLocator.com, we have a pop-up clinic, request a pop-up clinic portion of the website, which is just you going in and saying, hey, I don't see any providers in my area. Can you bring one to me? And I'm aggregating that access. So if we get 5 to 10 people in like a 30-minute radius from each other, we'll find a way to get a machine and a provider interested in that. That's enough of a demand signal that then we can take that demand signal and solve it. Like, so that's part of the solution. But you mentioned the rural health thing, like, yeah, I mean, the big cities where people will self-pay $250 an hour, they usually have some EECP access. Now, not in Chicago, mind you. There's only one place in North Chicago. It's like in Lake Villa or something, and they just opened recently. So for whatever reason, Chicago is like a ghost town for EECP access. But what we are seeing with the long COVID studies and dementia studies and kind of this growing awareness is some individual innovative providers that like already do some off-label stuff as a kind of a common part of their practice, are increasingly getting these machines and putting them to use in their local communities. I've seen just in the few months I've really been throwing myself at this and creating the Locator site and releasing the book, I've seen, I think, about 5 of them pop up nationally. So that feels really good. We still have all the problems of the few providers we have that only use it as like a salvage therapy last resort. And then even when you call them, they're like, ECP what? Well, and then you kind of like, your website says you have a machine. And they're like, oh yeah. You're like, wait a second. There's an awareness piece to this as well as an access piece, but none of that solves the insurance issue, which is going to be really important to like a lot of folks are on Medicaid in a rural health community. But I will say this, like, there's a way to make money off these machines. I'll tell you what, this is I think you're gonna like this. I'm curious. Okay, this is how I think we're gonna get to my dream of an access point every 30 minutes. I've been really noodling on this because I've been like spending 5 years of nothing but study on ECP in all my spare time. And like, why hasn't this become a thing? Because it works so well, and I've seen
That's actually the question I wanted to ask you. Like, why has this? Because what's the thing that is creating the barriers for providers to expand the access? So go ahead.
It's an awareness piece. It got stuck in cardiology, and they only ever used it 35 times, and it works really well with 35 times, but it works really, really well with 70. And you just add it just works better the more you use it. And so, so cardiologists have had other incentives, they got stents that came out about the same time this thing came out. And, the stent is like a quicker answer. It's not a better answer, but it's certainly a more profitable answer, and it's a quicker answer. And, then you started seeing these cath labs pop up and like outpatient centers all over the place. And then there'd be a new heart wing in your local hospital. And, that's where all the money was going towards procedures. Well, you got to, if I'm a cardiologist and I have 6 rooms for patients, I don't know that I'm going to tie one of them up with an EECP machine that I got to staff a tech on, and I got to have somebody in that room 35 times in 7 weeks. And if I put a stent in that same person, I get $10,000 in 2 hours. But if I have them go into my office that I had to staff and pay for all that for 35 times over 7 weeks, I might get like $5,000-$6,000. That choice is pretty simple. Like it's a systemic issue. I can't say that I blame the cardiologist. I'm a little frustrated because like they make enough money, they should be like doing the right thing in many instances. But at the same time, I get the basic economics. Like the system is just kind of broken. But this is the thing I want to highlight. I think rural health people are entrepreneurial because you kind of got to be in a rural health environment. And I want to challenge people's entrepreneurial spirit here because what I propose is this. Let me go back to that indication I said is going to matter when I said for healthy populations and general circulation. In 2015, the FDA for the first time approved EECP for healthy people for improved circulation. So we're not treating angina or dementia or anything. We're just making you have better circulation. General concept. There's a few caveats to how you could safely and, from a liability perspective, implement that. But it can be done. And so here's the model that I see. We provide you, like, let's say you, Chanas, needed to use EECP. And there's all kind of challenges to you doing it. You don't got a provider anywhere near you. You're in Chicago. You don't. And getting anywhere 35 times, even if it's close, is still not easy. But what if we can get a machine into your house? Okay. And it's going to cost you some level of money. I'm not going to pretend like this is free, but I will say this, like, I would drive the crappiest car in the world before I would be without my EECP machine. I would make a lot of sacrifices in my life because that's how important that machine is to just my oversense of how I'm going to feel when I'm 60, 70, 80, and, whether I got to worry about the next heart attack or the next stroke or whatever. And because I can help a lot of people with that one machine too. But anyhow, so if we get that machine into your home and you use it to fix yourself and we help you, like we train you how to do it and we monitor you so it's safely done and everything, and you at this point, you're addressing your own issues, right? A couple months later, you're going to start to feel like you're in a different space. What if we let you hang on to that machine and then you become an EECP access point, and then you start making money off of that machine yourself, and it paid for the money you already put out, and then it's a source of revenue for you in perpetuity while you're also giving back to your community. And now all of a sudden you're one of those access points. We can do that. I have a way to make this happen, and I think that's actually how we solve this. I'm not waiting for cardiologists to solve a problem that they haven't solved in 30 years. I'm not waiting for any other conventional medicine folks to do that. Like, it's not going to happen. Like, we're going to have to, bring this solution to the people. But when you heard those like, this is like a national security issue. Or let's put it in Africa for a minute. It's no different over there. Like this is just viable everywhere, period, because the barrier to entry is really pretty low, all things considered. We're talking about like the price of a decent used car is the barrier to entry. It's not crazy. Like the payback on that little business model I propose is probably like a year. Like the front end money and the money, like a year later you could be completely profitable in that whole thing, like in perpetuity. That's not too shabby. Like, people could be making $60,000-$70,000 a year running their own little ECP access point. I'm not saying you're going to make 100 and whatever, but like, I mean, money that you can feed a family on type thing. And so, but what if we had all these access points? What if we had the number I'm talking about, maybe even more than that? What if everybody used the ECP instead of, like, as they noticed their memory was fading, instead of going into, we know that track. We all know somebody that is been struck by dementia. We know the burden on the caregivers. We know the burden on the healthcare system. What if we didn't have to do that? What if, I know this is like, I keep talking about erectile dysfunction, but it's like not enough thing. Like, men get really frustrated, and it's not like it gets in our heads, having been on the other side of it now. Like what if we had a treatment for that? What if the dialysis centers weren't like everywhere else? What if those were all ECP access points and people didn't have to have their systems slowly shut down and die? Like what happens when you go on the diabetes? On dialysis, you don't, I've never heard of anybody getting off of dialysis unless it was a really temporary situation. What if we could really meaningfully move the needle on Parkinson's disease? And so, if what I'm talking about were to be reality, I think we would be a happier, healthier, more secure country. And I think any other country that did the same thing would too. And we're talking about China. Well, China, like, the president just went to China, or he's over there now. I don't know, but like, China has 5,000 access points, and some things are going right in China. So, like, let's maybe stop and look and say, is this part of it? It very well might be. Like, they have 5,000 access points. We have 150. So,
well, 150 in the US, 5,000 in China. And what I am seeing, or what I have heard you say, is that in an entrepreneurial country like the US, incentives definitely drive the direction of treatment. And that is what you're also describing with, the access point conversation that you're talking about. Because then, people be incentivized to look at, okay, how can I be part of this? I provide access, but I also can make a little bit, not become a healthcare professional, because that's still
That's not what we're talking about.
that's still the expertise of a cardiologist or a medical expert, but at least you become a closer. For instance, I'm surprised that a whole state like Illinois and a whole, global city like Chicago, you're saying is just one, it's just one ECP provider that is here.
Way up north. It's not easy to get to.
That's marveling,
I think down south, like I mean, I don't know. There's not one in Southern Illinois that I'm aware of. I think you get to St. Louis before you get to the next one.
Wow.
Yeah.
So, but let's go for a quick break. When we come back, we will discuss this model, in more detail on how we can use that to improve rural health access.
Do you want to help drive rural health forward? We're looking for passionate volunteers to support our work, from research to storytelling to business outreaches. If you believe every community deserves care, join us. Visit the link in our bio or show notes to sign up.
Welcome back. So, Jack, instead of waiting for healthcare system to solve the access problem, you already started thinking differently about delivery. What gap are you looking to bridge beyond just making sure that people have access to ECP
I want
machine?
people to have a choice. I want them to have this information about what EECP can do based on the research, not about what I'm saying. I mean, I got my own personal story, but let's look at the research.
Mm-hmm.
I just posted 90 patient testimonials on EECPlocator.com. If anyone wants to go look, I categorized them by condition, so you can really go through. And that's not just those are other people's stories. You grab those. But all the research is on EECP Locator, broken down by condition and by study. It's it's easy to navigate with a whole lot of complex information that you've got to get through if you really want to understand it all. But hopefully it's easy to navigate. It certainly should be really easy to find your closest access point, and hopefully there's one close to you, and hopefully they'll want to treat you, and hopefully your insurance will cover it and all these things. But if none of those are true, what I really care about is that if you think I want to know that you know that EECP exists. And then if you can hopefully make the connection between whatever the doctor's offering you, if it's not EECP, and then what EECP might make sense to use given whatever you're dealing with, and I'd like EECP to be reasonably close so you could actually do it if you wanted to, and reasonably cheap or completely covered so you can try it. Then I'll be happy. That's what I'm trying to accomplish. How we get there is not going to be one solution. We got to layer solutions like everything else. It's not one size fits all. But we have the hey, go on EECP Locator and let us know that you would like something to be in your area. That's a really helpful thing. I can't promise you put the request in, all of a sudden the machine's going to show up at your door, but that really helps if people do that.
I wanted to add on because I know that prior conversation leading up to now, you had mentioned this pop-up clinic, and you've talked about access points. Beyond individual, I wanted to ask, could local clinics, rural hospitals, or community health centers partner with you in this kind of model to expand access? Say people are not comfortable to go to other people's house. However, they are comfortable to go to a nearby clinic that is 30 minutes close to them by your matrix.
Great point.
These people partner with you?
Absolutely. And that, if you're that patient that you're like, this is where I'd be comfortable doing this, you talk to those folks and say, hey, or better yet, talk to 3 or 4 of your friends and get all 3 or 4 of your friends to say the same thing, right? Mm-hmm. And let them know that there is a demand signal that's not just you. But I mean, you can persuade these providers. Like, that's a lot of that. The little access points that have popped up this year, it's almost exclusively been somebody that demanded it be in that area. However, yeah, you can absolutely call me. So, like, one, the tech has gotten more portable. It's gotten a lot cheaper. The price points that people might hear floating around are not necessarily the real price points. I bet you they're a lot better than you probably think. If you're a provider out there, if you're a patient wanting to talk to your provider, know that and reach out to me. Okay. Also, we've got training now on the EECP Locator. It's not all the way done, but it will be done within the next couple of weeks. Advanced and beginner level for technicians, for providers, and for patients, just to understand. If you want to like take a course on it, you can. I mean, there's, the complexities of the heart and how the machine works. There's a lot to know and how to maximize the treatment and make it, and there are some safety concerns that need to be addressed and so on. Like we're covering all that soup to nuts in a really, really well done training. But yeah, like if you're serious and you express an interest, like there is a solution. We'll find it's not going to be a one size solution. There's going to be a lot of variables, but for folks that are serious when they've looked into this, like just don't give up. Like let's partner together. We'll figure it out,
Thank you so much, Jack. So as we begin to wrap up, I usually like to close on a more forward-looking positive note. So I'll ask you a couple of questions. So feel free to choose anyone and answer them. The first one is, what do you wish more healthcare providers understand about patient navigating serious illness? That is one. Two is, what would you say to rural patients who may feel a little bit out of place with this conversation? How would you reassure them? And the third one is, as you continue to walk along this line, what will success look like for you in the next 5 years?
All right. So for one, I think providers get a lot of information. My own beloved younger son is about to finish up medical school, and you know how many hours or even seconds he's spent learning about EECP? 4 years of medical school, what I'd like providers to know is that blood flow plays a bigger role than they might think in about every disease process. We talked about off-label conditions early in the conversation. I had a gentleman who was like wondering about macular degeneration in the eyes, and I was like, hey, look, there's this study and that study and that study and that study, and they all point in the same direction, which is like, this is probably really helpful for your eyes. Like, blood flow is key to aging, and aging is when we all start to get the names for all the symptoms that we call diseases. And so that's to the provider. For the rural health person, that's that this is a foreign conversation in a way, I guess one, I would say look up a locator site. A lot of them offer free sessions. Like your first session is free. Like if you're traveling, we're all traveling here and there, like you're probably going by one of those 150 access points. Not all of them will do this, but some of them will. Like swing by and be like, hey, can I get on your machine once? Because it says you can do it for free. Get familiar. Like, what do you got to lose? It's an interesting little experience if nothing else. I say this to the rural health folks, from the bottom of my heart and in the most loving way I know how. Like, it's your health. It's not anybody else's health. And if you go to the doctor expecting the doctor to have the answer, man, that's not in your best interest. You got to be your own advocate. And if EECP or any other thing that you find that really makes sense, you need to have a conversation with your healthcare provider. You got to demand that person's time and not be afraid to fire that person if they're not suited. Find someone who does, because we all only live once, and like, it's our health. It's not anybody else's health. And what does success look like? These access points every 30 minutes. I mean, that to me is acceptable. It's acceptable for somebody to go 35 times 30 minutes within a short period. It's not great even as is, but it's in the world of the possible for most people. And like you said, not everyone has a car. And I'm not saying it's everyone, but but it to me is a satisfying starting place for it to be realistic for everybody to give it a try. And at that point, I'll be content. I'm not really going to be content until then because this is just too important. I'm not going anywhere. We got to have this happen. So.
Thank you. So one of the recurring themes that I hear coming out of this podcast is that healthcare innovation means very little if geography continues to determine how people benefit from it. So today's conversation is reminding us that access to care is not just about whether treatment exists. It's about whether ordinary people can reach that treatment in time, if they can afford it, and sustain the journey that is required to receive that care. So as we continue to rethink rural healthcare system here in the US and globally, perhaps one of the biggest questions we must ask is not only what innovation we create, but who that innovation is ultimately designed to reach. So, Jack, thank you so much for joining us today on What About Rural Health podcast.
Yeah, it's been a pleasure. I had a great time talking with you. Thanks, Janessa.
Thank you so much. Thank you so much. I really did enjoy this conversation.
Me too. This is great. It really was.
To everyone listening, thank you for joining us today. If this episode changed you, taught you something new, or made you think differently about rural health, please like and share this episode with someone working in rural health or in healthcare, or a policy person or researcher, or even community advocates like Jack, because rural health is not just a niche issue. It is a public health concern, and Jack, you made that very, very clear. I would say that people should actually reach out to Jack, because I know a lot of us have circulation issues. Please reach out to Jack and make more inquiry about EECP Locator. Also, follow, subscribe, and leave us a review on your favorite podcast platform. It helps others hear about this conversation. And as always, let us keep asking the question, what about rural health? Until next time, I am still your host, Chinasa Imo. Bye for now.